All right, so we're going to get started this semester by just reviewing the basic anatomy and physiology of the cardiovascular system. So, the first part of this course, we're going to be focused on the heart. So, I want to really just kind of make sure we all have an understanding of what the heart looks like and how it functions and the electrical conductions that actually are transmitted through the heart. So, a lot of this is going to be review, but it's always a good place to start. So, a little bit about the heart. It's a component of the cardiovascular system, along with the blood vessels in the blood. As you're well aware, we have different circulations. We have a systemic, which comes out of the left side of the heart, goes to all the tissues of the body that need oxygen, nutrients, drops those off, and then comes back to the right side of the heart, whereas the right side of the heart pumps to what we call the pulmonary circulation, which goes to the lungs, where the blood can be reoxygenated with oxygen at the lungs. So a little bit of some basics. Four chambers to the human heart. The upper two chambers are called atria, and if you're talking about one, it'd be atrium. And then the bottom chambers are called ventricles. And the atria and ventricles are separated by what are called septa. So you have an interatrial septum and an interventricular septum between the left and right sides of the heart. Then you have valves that are between the atria and ventricles, and also between the ventricles and blood vessels. So the atrioventricular valves are between the atria and the ventricles. So the one on the right side is called the tricuspid. On the left side is called the bicuspid or mitral valve. And then the semilunar valves are between the ventricles and the blood vessels, or the arteries. So the aortic semilunar valve is between the left ventricle and the aorta. And then the pulmonary semilunar is between the right ventricle and the pulmonary trunk, which goes towards the lungs. So you can see a lot of those right here. So right side of the heart, here's your right AV valve, your left AV valve, pulmonary semilunar. We have your aortic semilunar right here. This is the aorta that's going to carry oxygenated blood to all throughout the body. Chambers, we have the atria up top, the ventricles down below. So that's a basic review of what the heart looks like. So a little bit about cardiac muscle. If you remember from basic anatomy and physiology, it looks a lot like skeletal muscle, but it is different in a variety of ways. So it is striated. It is involuntary, meaning we don't have voluntary control over it. As opposed to skeletal muscle, cardiac muscle is only going to have one or two nuclei per cell. The fibers tend to be branched to allow for better electrical conduction. And a lot of the calcium coming into cardiac muscle actually comes from the external environment around the muscle cell, and not as much from the sarcoplasmic reticulum as you see with skeletal muscle. But it still has sarcoplasmic reticulum that stores calcium and plays a role in contraction. Cardiac muscle fibers are very oxidative, so lots of mitochondria in there. And they're held together by these junctions called intercalated disc. And intercalated disc are a combination of two cell-to-cell junctions. One's called gap junctions, the other is called desmosomes. But the gap junctions basically allow the cardiac muscle fibers to work closely with each other. And so they allow rapid communication between adjacent fibers, and this is going to allow the chambers of the heart to contract as a unit. So here's a picture of cardiac muscle cell. So you can see the fibers are very branched. You see some of the striations in there. And then these little kind of openings, those are the gap junctions I was talking about. So they form what's called an intercalated disc. And that allows the cardiac muscle cells to work closely together. So external view of the heart. So you can see that you get a lot of vessels out here. We'll touch on those in a few minutes. And these are coronary arteries and coronary veins. And here's a more realistic picture. So coronary arteries, this is how the cardiac muscle receives its oxygen and its nutrients. So it supplies the cardiac muscle with oxygen and nutrients. And we're going to go through the anatomy of the coronary arteries. The relevance of this is that when we start looking at EKGs, if there's an abnormality in any of the EKG leads, that can kind of give us an idea of what part of the heart might be having trouble. And from that we can kind of deduce what coronary artery might be affected. So anatomy of the coronary arteries is going to be relatively important here. So the major arteries coming off of the left coronary artery, and I'll have a bigger picture on the next slide, but you can see coming off the ascending aorta, you have a left and a right coronary artery. And if we focus on the left at first, here's your left coronary artery. One branch of that goes right down the front of the heart. That's called the LAD, for left anterior descending. It's also known as the anterior interventricular branch. Then you have this little branch that kind of loops and wraps around the left lateral side of the heart. That's the circumflex. And then coming off the right coronary artery, we have this branch right here called the marginal. And then if we follow it around back, in the back of the heart, we have what's called the posterior interventricular artery. So here's a bigger picture of that. Here's your left. Get the LAD right here going down the front, the circumflex wrapping around the side, and your right coronary artery. Here's the marginal branch, and then in the back, we have this posterior interventricular branch. So just like we have coronary arteries, we have coronary veins. I'm going to focus less on these. I'm just going to say, for the record, there are coronary veins. They do have names, but they all drain into something called the coronary sinus, and that's on the back of the heart, and that receives the blood from all of the cardiac veins. It eventually is going to empty into the right atrium, and from there go to right ventricle, back to the lungs to pick up more oxygen. So here's a picture of the coronary sinus, and you can see there are other coronary veins that kind of drain the deoxygenated blood away from the cardiac muscle. But here's the coronary sinus, which is going to empty into the right atrium. So the cardiac cycle refers to the contraction relaxation cycle that the heart goes through on a regular basis. We can divide this into a lot of different subcomponents, but for right now we're just going to keep it simple and say that the heart contracts and then it relaxes. So the contraction phase is known as systole. The relaxation phase is known as diastole. So systole, contraction, diastole means relaxation. So what causes this to occur? Basically, it's the cardiac muscle cells or fibers contracting, and they're going to be stimulated by electrical impulses. And we'll talk a little bit more about that, because this is really what we're interested in with the EKG. We're actually measuring that electrical conduction through the heart. So similar to skeletal muscle cells, they do need electrical impulses to generate muscle fiber to contract. However, the way that this electricity occurs is a little bit different in the heart. So electrical activity within the heart is going to stimulate this cardiac cycle. So that brings us to cardiac electrophysiology, which is just referring to the electrical flow through the heart. So cardiac muscle cells contract in response to electrical signals, just like we said. So just kind of as a guide, you can kind of remember how skeletal muscle contracts. So you remember skeletal muscle fiber is innervated by a motor neuron, and that when that motor neuron conducts an action potential, it's going to stimulate the release of a neurotransmitter at that neuromuscular junction, which is going to stimulate a whole cascade of events that's going to allow that or stimulate that skeletal muscle fiber to contract. So it's kind of like that, but the electrical part is a little bit different in the heart. So all cardiac muscle cells are going to have what's called a resting membrane potential. And when a cell has this, any cell of the body, we say it's polarized, meaning there's a charge difference between the different sides of the cell. Inside is more negative than the outside. So in cardiac muscle cells, this difference is 90 millivolts. So we say that the ventricular myocytes, or we'll say cardiac muscle cells, have a resting membrane potential of negative 90 millivolts. There's a few reasons for that. One is just the concentration of different substances on either side. So you tend to get a lot of positively charged ions outside of the cell, more negative things like proteins and phosphate groups inside the cell. So that plays a role in it. But it also is a lot more complicated than that. It has to do with the permeability of the cell membrane to these ions. And I don't want to get too much into this because this is a discussion for another class, but in cardiac muscle cells, and this is true for most cells of the body. The cell membrane is most permeable to potassium at rest. So you get a lot of this potassium kind of leaking out. That's going to make the inside of the cell more negative. And that's pretty much the main reason we get this negative resting membrane potential. All right, so hopefully you remember what an action potential is. So it's just an electrical impulse. It's a wave of depolarization followed by repolarization. If you look at the action potentials in a neuron, which is probably what you've seen before, it's you have a period where the neuron depolarizes and then it repolarizes. So that is going to be also true in cardiac muscle cells. It's just the way that it happens is a little bit different. So action potentials occur when the membrane potential rapidly depolarizes and then repolarizes. And just as a reference, remember what happened in neurons and skeletal muscle cells, and this is where this picture comes in. So this is just the action potential graphed out in a neuron, and this is the classic picture that you've seen in undergraduate courses back when you took bio or anatomy or physiology. So they're saying a resting membrane potential of -70 in neurons. Some stimulus causes the membrane potential to hit a threshold, and then you get this rapid depolarization, which is basically bringing that membrane potential towards zero and even past zero from where it started. And then a very quick repolarization follows, where it goes back towards its resting membrane potential. And so if you remember from basic bio courses, sodium inflow into the cell was responsible for this depolarization, whereas potassium flowing out of the cell is responsible primarily for the repolarization. So if we compare that to what goes on in a cardiac muscle cell, you can see that there's a pretty big difference. So the green line represents a neuron. So quick depolarization followed by a quick repolarization, and it's done relatively quickly. If you look at what goes on in a cardiac muscle cell, you still get that rapid depolarization, which is due to sodium flowing in, but then you kind of get this sustained plateau effect, and it's a very, very slow repolarization. So a lot of that is due to calcium. Actually, calcium plays a role here, and again, this is a discussion for another class, but the point I really want you to see here is that there's a sustained kind of contraction and sustained repolarization. This is important in the heart because it's going to prevent cardiac muscle cells from going into what would be a state of tetanus. So you don't want cardiac muscle cells to just have a sustained contraction, because then they wouldn't be effective at pumping out blood. So you want to make sure that you get the contraction and then the relaxation effect. So to ensure that, you have this long repolarization period and this plateau phase, and that kind of ensures that the cardiac muscle cell won't go into that state of tetanus, and which would be detrimental to cardiac output. All right, so as far as the cells that you're going to find in the heart, I think of it as 3 different types. Most of the cardiac cells are going to be basically your cardiac muscle cells. We'll call those non-pacemaker. So these are basically the myocytes or muscle cells that make up the bulk of the atria and ventricles. Their role is to contract, but they have to be stimulated by something, and they're stimulated by these pacemaker cells. So these pacemaker cells make up what we call the cardiac conduction system, which you've all learned at some point. That's the SA node, AV node, bundle of His, bundle branches, Purkinje fibers. All of those things make up the cardiac conduction system. So their role is to basically spontaneously depolarize. And so the SA node in a healthy heart, you probably all heard that it's known as the pacemaker, because every second or so it's going to spontaneously depolarize and send out a wave of electricity across the heart that's going to flow down the rest of that conduction system. And that in itself is going to stimulate those other cells, the non-pacemaker cells, to contract. And so you get this kind of very organized flow of electricity through the heart and this very organized contraction of the heart. So I'll show you a picture of the cardiac conduction system next, which will hopefully better explain that. But the other thing I did want to mention, they do have these other cells that are just conducting cells. And these form these tracks within the heart. And I'll show you those also. So you got pacemakers, which spontaneously depolarize, the non-pacemaker, which are basically the cardiac muscle cells, and then these other conducting cells, which form little tracks within the heart. All right, so the classic cardiac conduction system consists of these components: SA node, AV node, bundle of His, bundle branches, Purkinje fibers. If we look at a picture of these and kind of go one by one through it, because this is really what an EKG is measuring. It's measuring this electrical flow, so it's really important just to kind of understand the location of these pacemaker components in the heart. So starting with the sinoatrial node or SA node, it's located in the right atrium near the top, and this has the SA node has the fastest spontaneous depolarization rate, and we say it's anywhere between 80 to 110 times per minute. That just means by itself it's going to have that intrinsic rate. This gives us what we call the intrinsic heart rate, which is the rate that the heart would contract without any external influence whatsoever. So when it depolarizes, it's going to send out this wave of depolarization, and that wave of depolarization is eventually going to reach the next component, which is the AV node, and it's going to go all across the atrium. So it goes from the right atrium to the left atrium, and there's also an internodal tract here that helps with that conduction, which you'll see. So if you look at a time course of this, it takes about 0.03 to 0.07 seconds for that impulse to get all the way here. And when it gets there, this is the AV node, the electricity is going to continue to flow down the rest of this system. So when the electricity gets here to the AV node, you get this slight delay because the cells are really, really narrow, and it actually slows the conduction down a little bit. And I put this little thought bullet point here, the significance. What's the significance of that? That's going to be important because that's going to allow the atria to finish their contraction, or almost finish their contraction, before the electricity gets to the ventricles. So the atria, we're all probably aware that the atria contract before the ventricles, and that's pretty much why you get that electrical delay right here at the AV node, which allows the atria to contract first before the ventricles are stimulated. So the AV node itself has an intrinsic rate of 40 to 60 times per minute. So in a situation where like the SA node failed, the AV node would generally take over, and you would just have a slower intrinsic heart rate. So throughout the semester, we'll be talking about what are known as sinus rhythms versus atrial rhythms, or I guess a better description would be nodal rhythms or AV junction rhythms. And one way you can tell the difference, there's other things that are important, but there's just the rate. So if I go back here, look at the intrinsic rate of the SA node, 80 to 100 times per minute. And so any sinus rhythm that we talk about when we look at EKGs, meaning it's originating at the SA node, it's generally going to have a rate in that range. So we always say as a rule of thumb 60 to 100, but sinus rhythms originate here, so their rate is generally going to be higher. The AV node makes up part of what we call the AV junction. The intrinsic rate is a lot slower. So our junctional rhythms, as we're going to call them, have rates that are within the range of 40 to 60 times per minute. So you'll see more of that in the upcoming weeks. All right, so the next component, bundle of His. This is kind of bridges the atria and ventricles, and also intrinsic rate of about 40 to 60, because the AV node and the bundle of His together generally are just referred to as the AV junction. And that's what I was alluding to when we say that we have junctional rhythms that originate in this area. So after that, the electricity is going to flow down the left and right bundle branches. And these are in the septum of the interventricular septum. And there's a right and a left. And if you look closely, the left is a lot more complicated. So if you look at this picture right here, there's 3 different fascicles. And that's going to allow better flow of electricity through the ventricles. So You can actually detect this sometimes on EKGs, like what fascicle might be affected if there is an issue. But uh, as far as the location of these, I mean, you can pretty much just know that they're there, and I put a description of where they are. But the left um, bundle branch does have these fascicles, the right does not. So the left is a lot more complicated. All right, and then lastly, the Purkinje fibers. These are the tiny little fibers running through the ventricles. These just stimulate the cardiac muscle cells within the ventricle to contract, and they have an intrinsic rate of 20 to 40. So if you think about that, if everything else fails, the SA node fails, the AV junction fails, then the ventricles take over. And if we get what's called a ventricular rhythm, it's usually not very good. One reason is that the rate is so slow. So you could imagine if your heart all of a sudden went into a rate that was 20 to 40 beats per minute, cardiac output is really, really going to drop. And so usually we consider our ventricular rhythms to be really dangerous. All right, and then those internodal tracts that I was talking about. So one of the big ones is something called Bachmann's bundle. So you can see there's kind of this connection between the two atria. So Bachmann's bundle, and then you also have just different pathways through the heart that are kind of hardwired, and so they're not necessarily part of the conduction system. They're just separate, like kind of tracks that electricity can flow through to get a better flow of electricity through the heart. And here's a better picture. So you see the Bachmann's bundle, and then these other tracks between the SA and AV node. All right, and then, so just kind of putting all this together, if we look at a time course of this, so in a normal contraction of the heart, the SA node is going to be the pacemaker. It's going to depolarize. The action potentials travel across the atria through some internodal tracts and also just cell-to-cell conduction. The conduction velocity in the atria is about 0.5 meters a second. And then when it gets to the AV node, it slows down. And look at the speed, it completely dropped. So the speed of electrical conduction at the AV node is 0.05 meters a second. So this is where you get that delay due to the narrowing of the fibers. So again, why is this important? It allows the atria to contract before the ventricles. That way we optimize the filling of the ventricles before they contract. Also, as a side note, it does protect against dangerous arrhythmias. So by kind of slowing the action potential here, it does kind of prevent the ventricles from going into an abnormal rhythm. So instead of giving them too much electricity at one point in time, it kind of slows it down so they gradually get it. All right, then action potential is going to go to the bundle of His, and then it's really moving. Look at the speed, really jumped up. And then as it goes down the bundle branches, about the same speed. And then by the time it gets to Purkinje fibers, the electricity is really flying through the heart. So 4 meters a second. So you can see that the speed changes throughout the different parts of the conduction system. All right, so putting it all together, we kind of see, if we just said when the SA node depolarized, that's 0 point in time. And so you can see it takes about, let's say 0.07 seconds to get to the AV node, 0.09 to get out here, and then it goes up to 0.16 just to get from here to here. So that's where that slowing occurs. Then after that, it really moves quick. So even from here all the way to here, it's only from 0.16 to 0.18, and then even from there all the way up here to 0.21. So you can see the biggest slowing occurs right here. All right, just lastly, so we established that the heart is going to have what's called an intrinsic rate that's set by the SA node. But, and it's not about, I put 80 to 110 on the previous slide, 90 to 110 here. It's somewhere in that range. So we all know a resting heart rate is usually not that high. So there must be some external influence on that. And we also know during exercise that the heart rate can go way above that. So there must be some external influence. Most of this is your autonomic nervous system. So you have your sympathetic branch and your parasympathetic branch. So parasympathetic is traveling in the vagus nerve, so we'll call that vagal activity. So you can see you have your intrinsic heart rate that can be increased by sympathetic outflow or decreased by parasympathetic outflow. And then hormones and ions can also play a role. But the bulk of this is your autonomic nervous system. And when the heart rate changes, the name that we use for that is chronotropy. So if something increases your heart rate, we say that's positive chronotropy. If something decreases your heart rate, we call that negative chronotropy.